Hi, everyone, and thank you for joining us today. I'm El-Khoury, and it is my pleasure to be having this discussion on machine learning and laboratory medicine with Dr. Stephen Master. Dr. Master is Chief of the Division of Laboratory Medicine at Children's Hospital of Philadelphia. He is also the Director of the Michael Palmieri Laboratory for Metabolic and Advanced Diagnostics. Steve, welcome, and thank you for joining us today.
Well, thanks for having me, Joe. I feel like I've now arrived in my pilgrimage to the home of clinical chemistry media, so thanks again for having me.
So for the first question, for anyone who's not familiar with this topic, because machine learning can be quite complex, I know many applications have come out, so you can probably reference ChatGPT and others, but in layman's terms, how would you describe or define machine learning for somebody who's not familiar with it?
Machine learning is all around us at this point. We're using it on a daily basis, and you see this every time you interact with a company on the internet, for example. So if you think about going to Amazon or you think about going to Netflix and you think about the recommendations that they make, those are all based on machine learning. So what's going on? Well, let's say it's Netflix, and Netflix is trying to predict what movies you may like to watch. It may do that based on knowing what other movies you have watched in the past. So it's got a database of everything that everyone has watched and then can mine that database to ask how many people who watched movie A also watched movie B and liked it. So then they can make a prediction about the future. But there might be other things that Netflix knows about you. It might know how much of the movie you watched. So maybe if you watched the whole movie, that means you liked it and you're likely to like something else. Maybe if you stopped halfway through, that's a clue that you didn't like the movie and there's a set of movies that it shouldn't recommend for you. Well, now we're talking about two different variables. We're talking about, did you watch the movie or not? We're talking about how much of the movie did you watch? So you can think about that as an x-axis and a y-axis. And so maybe if you watched the movie and only got halfway through, that means you're less likely to like another movie. If you watched the movie and did get all the way through, it means you're more likely to like another set of movies. And if you didn't watch the movie at all, well, we don't have any information. Now we're starting to talk about making predictions on multiple types of information, on multiple variables. That's easy if we think about one movie and whether you watched it all the way through. It's really difficult if you start talking about thousands of movies and thousands of variables about how much of it did you watch and did you pause it and then come back later, all sorts of things like that, that for us as humans are difficult to sort through. So what machine learning does is to provide a set of tools to allow you to take that high dimensional information that is lots and lots of variables and to make predictions based on that high dimensional information. So a variety of machine learning algorithms allow you to take a training set based on data where you know the answer, you know whether the person liked the movie that's the hypothetical movie in the future, and then use that training data to predict for a new person based on their prior movie watching habits, whether they're likely to like a movie. So that's analogous, of course, to what we want to do in laboratory medicine. We have a lot of data that we're collecting. We have data that are coming off of chemistry analyzers, and we have genomic data, and perhaps in the future, metabolomic data. There's all sorts of types of data that we look at that are inherently multivariable. If you were to plot those on different axes, if you were to even take a basic metabolic panel and plot sodium and plot potassium, and pretty soon you realize you can't fit this on a sheet of paper. We're very good as humans at navigating three dimensions. We're well evolved to make our way through three-dimensional space. When we start talking about thousands of dimensions, we can't make sense of it. And again, machine learning is a set of tools that allows us to build a predictor based on the high-dimensional data that will then ask the question, can I predict what's going to, what an outcome in the future, a disease outcome, a diagnosis, things like that. So that's what machine learning is in a nutshell. And that's how what has been going on for quite some time in the commercial space is so relevant. That's the way it's relevant to laboratory medicine.
Well, that's excellent, and it's remarkable to see all of these kind of futuristic sounding like advances with machine learning that we could kind of do. But really, I guess it's important for me to ask, given the description you've given, is this truly futuristic, or do we have some applications in lab medicine today that are using machine learning that are important for laboratorians to know about?
In most cases, it's in the very near future. It's still a little bit futuristic. In many cases, we haven't well solved the problem of how to get that implemented in our laboratories, but we know it's going to work. I'll give you an example from some work that our group did. a while back now, probably 9 years ago, looking at hematology analyzer data. So we all run hematology analyzers on a regular basis, and we know that they give us the CBC parameters that we report out in the electronic medical record. It turns out that most of the large vendors also keep track of a large number of other variables that they don't report. And those other variables are mean neutrophil conductivity, things where I have no idea what the clinical significance is, and therefore we don't report them, but they're being collected every single time you run a specimen. So we asked the question, can you use these hidden parameters to predict myelodysplastic syndrome? This just happened to be the thing that we were looking at. And so in a consecutive set of cases, we pulled out the patients who had MDS. We eliminated people who were on chemotherapy who would have really radically altered CBCs. And we started to look at these hidden variables. And it turns out that we could do a very good job of predicting who had risk of myelodysplastic syndrome, who had MDS, and who needed to be further screened. What was interesting about this was that when we actually looked at the variables that were driving that classification, remember I talked earlier about the variables and the different axes, when we look at the ones that turn out to be the most important for driving that classification of MDS versus non-MDS, the most important variable was something called platelet distribution width. Now, most laboratorians know about red cell distribution width. It's basically how variable are those red cells? What's the width of the histogram of the cell size? The same thing is true for platelet distribution width, except as you know, nobody reports platelet distribution width. But if you think about it, if you think about myelodysplasia and you think about abnormal megakaryocyte function, it makes sense that you would have platelets that are messed up, platelets that are more variable. So ironically, by using machine learning, we almost had a discovery tool. We were able to show, A, that we could take these hidden parameters that are not being reported in the electronic medical record and make valid predictions. But we also showed that there was some biological sense that we were finding, that in fact, that retrospectively, we could see the way in which there was a scientific rationale for what it was we're doing. So I think we have some examples like that in the literature where it's very clear that this is going to work. But let's get back to your question about is it in the now or the near future? The challenge really has been the integration of this with our current lab informatics infrastructures. So in order to use the kind of information that I just told you about, I have to have all those parameters downloaded. Well, how am I going to get them in? They're not in the EMR. So where am I going to get them from? I'm going to have to go to the middleware. I'm going to have to go to the instrument itself. And then I'm going to have an informatics infrastructure that allows me to pull that in real time, do my classification, and then fire off a reflex to say, now you need to make a slide from that tube. There's a lot of complications there, a lot of operational complications. So I think we know that this is going to work. And one of the real challenges for our field right now is so-called ML ops. How do we actually put this into practice and make sure that we maintain the quality of it moving forward?
Fascinating. So I know from some of the work I've been looking at, specifically in acute kidney injury, there's a lot of development in that space as well and trying to detect it earlier using machine learning. But we've seen a lot of variabilities in those studies. It sounds like in addition to the barrier you're describing on the laboratory side and having the ability to pull that data and use it in a meaningful way, what are some of the other barriers in being able to implement some of those other diagnostic tools into coming into that space? And I know, Steve, you've basically also been involved in an IFCC guideline that looked at some of those. So it's a guideline published in Clinical Chemistry, and I'll put a link to that for anyone interested in learning more about what are some of those recommendations. But basically, what are some of the other barriers that we see in this space, and how can we help address those so we can implement these things sooner?
Those are great questions. Let me start with the first part first. So what are some of the other challenges? Well, we've actually seen some machine learning kinds of approaches, some algorithms that take data and make predictions that have started to make their way into the medical record. There's a well-known example that tried to predict sepsis and had some issues. What are those issues? You talked about the AKI stuff. What are some of the challenges that you have when you start to implement some of these algorithms clinically? One of the challenges that we know about as laboratorians is we know that there's not always perfect harmonization or standardization between assays. And it's very clear that kind of bias in an assay from vendor to vendor, for example, could affect the output of a machine learning algorithm. So in fact, that's one of the reasons that I love talking about machine learning in laboratory medicine context so much, is that I believe so strongly that we have to be driving many of these processes, or at least we need a strong seat at the table, because we as laboratorians know about the weaknesses and limitations of the tests that we perform. And if someone naively takes those data and simply creates a machine learning algorithm out of it and doesn't understand that moving that algorithm to a different hospital that uses different instrumentation may introduce a bias, if they don't know that, then there will be bad outcomes and we will not have success with machine learning. So it's really important that we, not everyone has to develop machine learning algorithms, but I think that knowing something about the field and having a seat at the table to provide domain expertise is really, really important for us as clinical laboratorians. So that's the first thing I want to say. You talked about limitations, AKI. I would say that we've seen that in multiple spaces, and it's really important that we be involved, again, so that we can provide our expertise on the nature of the data that are being used to feed the algorithms. So then you alluded to the IFCC working group that published a guidance document in ClinChem not that long ago, this summer. So there were a couple things that drove that document. One of them is the things we've just been talking about, recognizing that there were a number of factors within the laboratory that would really influence the success of machine learning in a clinical context. That starts with asking the right questions. Is this in fact a problem for machine learning? What data do we need to have? How do we make sure that we don't conduct a biased study? There are all sorts of things like that that are important. And we talked about things like the issues with standardization and harmonization. One of the other things that really drove the need for that paper, though, I think, was the proliferation of papers in the literature that have been trying to apply machine learning to laboratory medicine. And one of the things that we were concerned about was to make sure that we had set best practices for the field so that there was not an over-optimistic estimation of how well machine learning was going to do. We need to control this well, and we need to get the right answer so we know exactly what it is we're giving to patients before we give it to patients. And specifically, one of the things that seems to have recurred over and over in the machine learning field is small errors that allow data from a so-called training set to leak into the test set. So let me back up and talk about terminology. So when we train a machine learning algorithm, we start with a set of data. I talked about the annotated data that Netflix might have. They know that people who have watched this movie like that movie, and they start with that information. And then based on that, they create the algorithm that then is used to predict whether someone will like a movie in a new context. Now, it is important that you keep the training set separate from a so-called test set. If all I do is to train a machine learning algorithm on a training data set, and then I turn around and ask, well, how well does this algorithm do in predicting the training set? I've really done nothing. I'm going to vastly overestimate the power of my machine learning. I could just memorize the data. I could memorize the right answer and not understand anything, and I'd get a wonderful result. I'd get, 100% specificity, 100% sensitivity, an AUC of 1. Everyone would, shower me with prizes. That's never realistic. That's not correct. And so it's very important that not only you not apply your machine learning algorithm back onto the test set because, of this memorizing problem, so-called overfitting, but it's also important that that test set be completely that the training set be completely walled off from the test set that you're going to actually use to evaluate whether or not your machine learning algorithm works. One of the things that we've seen is that there are very subtle ways in workflows that you can inadvertently allow data to leak through, therefore giving an over-optimistic sense of what machine learning will do. So one of the things that this working group document did was to try and lay out best practices to ensure that that does not happen. Again, we think machine learning is incredibly valuable for the future, but we're concerned because if we are not careful in the way that we apply it, then there will be bad outcomes. And we've all seen that in prior technologies. A lot of hype, some bad stuff happens, and then there's a backlash, and then we don't get back to using the technology appropriately for quite some time. And we think that machine learning has too much potential for us to fall into that trap that has happened with other technologies.
Wonderful. So who would you say this guideline is for? Is it mainly for individuals who are developing new machine learning algorithms, or is it for, let's say, the common laboratorian who's looking to do that? And that may be a simple this or that kind of answer. But also following up on that, what should the common laboratorian know or be worried about when it comes to machine learning? What is something that they need to be worried about today?
So I'm glad you phrased the question that way, because it allows me to clarify something. When you say people who are developing new machine learning algorithms, I don't think anyone in lab medicine needs to develop new algorithms. When I talk about building a machine learning model, I'm not talking about someone going in and saying, I have a new mathematical concept for how we can classify samples. It's rather that we're taking a number of existing algorithms that are getting easier and easier to use and training them with laboratory data. So there's sort of a middle group there between developing your own stuff, being an end user, but creating the model. And really what we're talking about this in terms of the guidance document is we're targeting that middle group, people who are in fact training the model. One of the things that's been a really interesting development in machine learning is this way in which it's getting easier and easier to use. You don't have to be a mathematician. You don't really even need to be a programmer. There are tools that are making it very accessible for many individuals to do machine learning with their own data sets. But the problem is, if you do that and you don't understand the underlying concepts, then you're susceptible to the things we were talking about earlier, to data leakage, to these problems if you make subtle mistakes. So that's where the guidance document was really aimed. It's aimed at people who are training a model to address a laboratory medicine problem and then publishing it, because we're very concerned that there be guidance for example, for reviewers and for journal editors to know what things meet the criteria to really be reliable and which things belong in the literature. So that's the first thing I'd say about that. Then the question you asked beyond that, though, about what people need in the laboratory need to know is, I think, a great question. I would argue that this is analogous to if you had asked me, 40 years ago, do people in the lab really need to know about immunoassays, right? And what we would say now, I think, is, well, you don't necessarily have to be a person who is an expert who develops your own immunoassays, but you need to know the principles in order to know what might go wrong so that you know how to best protect patient results and how to do the right quality control and what things to watch for, what are the pitfalls, what are common errors. And I would say that it is a reasonable goal for all laboratorians to understand machine learning and data analytics at that level. What are the things that could go wrong that might affect the results? If someone's coming in and saying, I've got an algorithm that's going to take your laboratory data and predict whether a patient has sepsis, you ought to understand at least enough to say, hang on, let's make sure that the model was trained using data from instruments that are comparable to the instruments we have in our lab. Let's make sure that our population is the same, et cetera. All the things that we traditionally do in laboratory medicine. Similarly, not everyone has to run a mass spectrometry lab. Not everyone has to know how all the nuances of mass spectrometry, but as a laboratorian in general, as a clinical chemist, you need to know enough to know what questions you should be asking and to know what you should be looking for in proficiency testing results and things like that. So I'm not sure that we have really the perfect description yet of what that looks like for a laboratorian who has no interest in training models. But I would say that is the analogous goal. I think we need to know enough to do the right quality control so that we are confident in the results that are coming out of our labs.
Excellent. So then the next logical question following that is, where would a laboratorian go to learn more about machine learning if they're interested so they can be prepared for that next phase?
So actually, there are some good resources that are becoming available, and in some cases freely available online. One that I would call out that is freely available is on the Area 9 Learning Lab. There's a module on machine learning that was produced by Shannon Heyman, Lee Jia, and myself. And that should be open to everyone. That's in a sort of question and answer format to try and guide you through some of the basic principles of machine learning. If you want to go a little bit beyond that, there are courses all over, but there's a course that Randy Julian and I have run for MSACL that will be offered again in the future. That's perhaps geared more for people who want to actually train their own machine learning models, and it really is an introduction to that. And beyond that, I know that the professional societies are really focusing on this. So ADLM has had some initiatives that are trying to develop more curricula that are geared toward the end user, really toward the laboratorian who's not interested in training their own models, but who wants to know something about machine learning. And I think, again, that really is a critical thing, because we have to be able to know going forward that we're able to maintain quality in our laboratories in an appropriate way.
Wonderful. So then finally, Steve, any recommendations would you give to clinical laboratorians related to what we've talked about today?
Well, I think I'd go back to what we were just saying. I would actually start with make sure you have a seat at the table. What we know about laboratory data is vitally important to the success of machine learning. And so having a hospital informatics group take over all the work of doing the machine learning classifier without knowing the nature of laboratory data would be a mistake. So I think it's really important that we do get that seat at the table, that we're involved. Being involved probably means learning the language, and it probably means knowing what's involved. And that means educating yourself to some extent about what machine learning does and how it does it. And so I would, again, offer the Area 9 course as one option. Certainly looking at the IFCC working group paper would be a great place to get a sense for what the field is doing. And then you could use that as a basis for searching out more that you don't understand. And then finally, make sure that you're ready for what's coming, because I would say that we have enough information to know that this will be clinically implemented. If it isn't already, it will be soon where you are. And we have to be thinking about what the infrastructure is that we need to support that. But more than that, we need to be thinking about what the quality metrics are that we're going to put in place to make sure that we continue to maintain our reputation of upholding patient care and doing a great job at our clinical work.
Thank you, Steve. That was wonderful. Thank you for sharing your perspective. And thank you all for watching.